Good afternoon, everyone. As part of the ongoing partnership between the New York State chapter of the American College of Clinical Pharmacists and the New York State Council of Health System Pharmacists, we would like to welcome you to our annual joint webinar entitled Long-Acting Injectable Antipsychotics and the Impact of Legislation Expanding Pharmacist Roles. We are thrilled to have Dr. Farah Khorassani and Dr. Jeff Brown as our guests who will present. Dr. Khorassani is a board-certified psychiatric pharmacist and a health science associate clinical professor at the University of California, Irvine School of Pharmacy and Pharmaceutical Sciences. As part of her academic appointment, she also practices as a clinical pharmacist in psychiatry at UCI Health. She received her BA in chemistry from the University at Buffalo, New York, and her PharmD from the Massachusetts College of Pharmacy and Health Sciences in Worcester, Massachusetts. She went on to complete a PGY1 pharmacy practice residency at New York Presbyterian Hospital, Cornell, and Columbia University Medical Center, and a PGY2 in psychiatric practice at University of North Carolina Hospitals. Her research interests include outcomes associated with pharmacotherapy of schizophrenia, including long-acting injectable antipsychotics, pharmacogenomics in psychiatry, and student mental health. Dr. Brown is a pharmacist with the New York State Office of Mental Health at the Buffalo Psychiatric Center and an adjunct instructor at the University at Buffalo School of Pharmacy and Pharmaceutical Sciences. He is also lead investigator at the Geriatric Pharmacotherapy Institute, a private nonprofit research and educational foundation that's conducted clinical trials in behavioral health for over 25 years. GPI has also served as a local care center coordinating and providing injection services for patients treated with long-acting injectable antipsychotics. Before we get started, I'd like to share a few quick points. For those that might have technological issues during the presentation, please use the chat option to communicate with the office. Every effort will be made to assist in resolution. For those who have questions that would like it directed to a speaker, please use the question box or the chat option. The CE code for this program will be provided at the end of the program, verbally and within the chat. Welcome, Dr. Khorassani.
Thank you so much. And looking forward to talking to you all today about my favorite class of medications, the long-acting injectable antipsychotics. Before moving out here to California, I was practicing at Bellevue more recently. And so this is something that's very close to my heart. So I'm looking forward to chatting today. I have no disclosures, and today the objectives are for the pharmacist to be able to differentiate between the different long-acting injectable antipsychotics, or LAIs, recommend appropriate dosing, discuss New York State's legislation regarding pharmacist administration of LAI psychotropics, outline the process for administering LAIs in a practice setting, and discuss the location, room, and supplies needed for administering LAIs in a practice setting. For the technicians, we'd like for you to be able to identify available LAI antipsychotics. As a quick reminder, antipsychotics can be used to treat multiple indications. For LAIs, specifically, we're talking about bipolar disorder, schizophrenia, and schizoaffective disorder, not so much major depressive disorder. Antipsychotics can be categorized as typical antipsychotics, which are the older versions, for example, haloperidol, and then you have your newer antipsychotics, and these are your atypicals, for example, risperidone and aripiprazole. Antipsychotics available in multiple different formulations. Today, I'll obviously be talking about the long-acting injections, but I want to make a quick distinction and just point out that some antipsychotics are available as immediate release injections, which are typically used to treat acute agitation. And so the injections that I'm talking about today are more for maintenance dosing of their medication. There's multiple antipsychotics that are available as LAIs, but not all of them. So these are some of the ones that I will be talking about today. I've highlighted the ones that you're more likely to see in clinical practice. So haloperidol, aripiprazole, and paliperidone are probably the most commonly prescribed. And so I'll try to spend a little bit more time talking about those because you're probably more likely to see those. Per the American Psychiatric Association schizophrenia guidelines, LAIs are recommended for patients with a history of poor or uncertain adherence. And really, we're trying to get as many patients on LAIs as possible in psychiatry. In general, this reduces medication non-adherence. It gives patients the opportunity to not have to take their medications on a daily basis. And it also, there's studies that suggest a 30% decline in relapse and rehospitalization when patients are on long-acting injectables. So these are beneficial to patients. And some studies even suggest that some patients report a better sense of symptom control while they are on LAI. So that makes sense. You may be thinking, why don't we just give everyone LAIs then, right? But there's a lot of logistical barriers. It's great that pharmacists are now going to be able to help with providing these injections, because that will help with some of the logistics and service barriers. But for those of you who immunize, you probably realize that some patients are scared of needles. And so I hear this a lot when trying to talk to patients about the potential of an LAI. And a big thing is cost. Many of these injections are upwards of $1,000 or several $1,000s. And we're lucky that, at least last time I was in New York, Medicaid covered many of the more common injections. But if someone has private insurance or no insurance, these injections are not very accessible. There's also a prescriber discomfort with these medications. I think in my experience, the pharmacokinetics is a little bit elusive, not knowing how to manage missed doses, late doses, reemergence of symptoms within the dosing range. So I think there's a lot of hesitance. And one of the things I've tried to do as a pharmacist is really do a lot of education with prescribers, residents, attendings, NPs, PAs, whoever's administering these, just to get them a little bit more comfortable on using these medications. One key thing with these LAIs is that you stabilize someone on the oral formulation of the antipsychotic, and then you give them the corresponding LAI. So for someone stabilized on Abilify, we're going to give them one of the Abilify injections. The injections are not interchangeable. Before you give someone an injection, remember, most of these injections are at minimum lasting 2 weeks, but at maximum lasting 6 months. You really want to make sure that the patient has established efficacy, meaning we see some sort of meaningful reduction in their symptoms. And then also we want to make sure they're tolerating the medication. We don't want to give them an adverse effect that they're now going to have to deal with for, at minimum, again, 2 weeks, but probably at least a month on this medication. And none of these can be reversed. There's no reversal agent. So just something to think about. So those are the two things we're looking at. It will vary on, some patients will respond quickly and we can give them the injection faster. Sometimes we have to wait a little bit longer. This is a little bit more elusive in terms of how do you know when. Most of the medications have pretty clear-cut dosing conversions from the oral formulation. So it's, for the most part, pretty easy, with the exception of a few where it's a little bit more flexible, and I'll talk about that. And then things to think about when you're transitioning is, do you need to continue the oral medication for a period of time or not? And that's going to be injection specific. I'll talk about which ones need that, which ones don't, etc. Lastly, you may be wondering, do people ever get 2 LAIs? Are they on maybe haloperidol and aripiprazole? There are case report data, but in general, guidelines suggest antipsychotic polypharmacy, whether it's oral medications or whether it's LAIs, is not effective for treating schizophrenia. Again, there's always going to be those outliers. I've seen less than 5 cases where we've had patients on 2 LAIs. And a lot of the times the question becomes, well, have they tried clozapine, a situation like that? So, but that's a whole separate issue. So if you are seeing someone on 2 LAIs, it's probably in the minority. You have different formulations of the LAIs. You have decanoates, microspheres, and suspensions. Not super relevant, but just so you can kind of get your mind around how they're categorized. And they're mostly injected intramuscularly, with a few that will be given subcutaneously, either in the abdomen or the upper arm. The decanoates are haloperidol and flufenazine. If you look on the right-hand side, you'll see a vial of prolixin decanoate. You can see there that it is viscous, it's thick, and it's made actually in sesame oil. So I'll talk about this again, but it's actually contraindicated in patients with a sesame allergy because it is formulated in that. Because it's thick and viscous, you will also see that it can cause some injection site pain. And I've also seen sometimes patients develop abscesses around the injection area just because the follicles get a little bit clogged. So just something to think about injecting potentially in the gluteal muscle as well, just because it can be a little bit more painful than, say, in the deltoid. The microspheres formulations are kind of unique where you have active drug encapsulated in these microspheres that have multiphasic release. So for example, Risperdal Consta is the more common one that you'll see here, releases over a period of 7 weeks. Both of these, any of the microspheres formulations do need to be refrigerated. So that's just something to think about. Most of the injections are aqueous suspension. So you have other risperidone injections that are aqueous, and then you have the aripiprazole, paliperidone, and the olanzapine injection. All right, so now to get into the nitty-gritty of these different medications. So you may be thinking, who even takes Haldol and fluphenazine anymore? These are medications from the 60s. But I will say we use this quite a bit at Bellevue. We use this quite a bit out here in California as well. Sometimes patients fail atypicals and we need to give them an LAI, and so we give them these medications. So the key is dosing it appropriately. So both of them are given intramuscularly. Again, it can be a little less painful if given in the glute, but deltoid is also fine. The dosing, so I mentioned that sometimes the dosing isn't very clear. And I would say for Haldol, that's the one specifically that I would say it's a little bit fuzzier. So your package insert basically says anywhere from 10 to 20 times the PO dose. They make some qualifiers that I'll talk about on the next slide to guide a little bit. But in general, I would say most prescribers will give about 10 times the PO dose. That's kind of my experience at several different hospitals, with some duration of oral overlap, perhaps about 4 injections or 3 months is kind of the practice that I've seen. Again, this is going to be prescriber specific. It's going to be site specific. You do have a lot of flexibility in the dosing. But what's pretty standardized is the dosing interval, which is every 4 weeks, which is one of the reasons why you're going to see this used a little bit more so than Prolixin, which is typically given every 2 weeks. Though if you look at the literature, a lot of the time it says every 3. But I've seen several patients, actually very few patients on Q3 week. It's usually a Q2. And the dosing is much more clear with Prolixin. It's really just going to be 1.25 times the PO dose. And then you'll kind of have to get a little creative with the oral overlap using some monitoring. So these two, in my opinion, are the most fuzzy in terms of dosing. So just, I think the take-home point is that you should expect patients in the earlier phases of these injections to also be on oral medication, because there is kind of this, you're trying to toggle between not giving too much and causing EPS, or giving too little and then you have symptom relapse. Something else about Haldol is the first injection you ever give, the maximum dose cannot be more than 100 per the package insert, and that is really just to avoid the risk of EPS. So if someone is stabilized on 15 milligrams, we give them 150 for their first dose. We'd give them 100 milligrams on day 1, and then we'd give them the next 50 anywhere from day 3 to day 7. So I would say that's probably the most common way to do it. Again, 10 times the PO. You have other loading dose strategies for patients on higher doses above 10 milligrams. So you can do 20 times the PO dose and maybe give them a little bit less oral medication. Or there is one thing that a loading dose regimen that I have not personally done before, but that is 10 times the PO weekly for 4 weeks, and then you consolidate it for the next injection to 20 times the PO. I think the risk of EPS is a little bit higher with that. So as far as I know, not many people use this. Again, avoidance sesame allergy. And the other thing I just want to say is these are administered, interestingly, using the Z-track administration. So you basically pull over the skin, inject, and then pull it back, just to get that kind of drug repository in the muscle there. So that this is the only injection, as far as I know, that uses this administration technique. You have multiple Abilify injections or aripiprazole injections. I'll start with the Abilify Maintena, probably one of the 2 more common ones. And then the newer agent, Asimtufi, was actually just approved in April. So I just wanted you to have this information for when it actually is available. But as far as I know, no one has seen this yet because it is extremely new. Maintena is very easy to dose. Pretty much everybody gets 400 milligrams in the deltoid or gluteal muscle, IM. And then there is a 14-day oral overlap. And again, I have seen patients who did not take the oral overlap after discharge, and then they ended up relapsing and being readmitted. So counseling point for these is make sure you take the oral overlap because it could lead to relapse. The other more common aripiprazole injections that you may see are Aristada. I know some of the hospitals in the New York area have this on the formulary. I know we did at Bellevue. So this is typically available in pre-filled syringes. Again, pretty easy to dose. You have very clear-cut dosing guidelines based on the oral dose, anywhere from 10 to 20 milligrams. What makes this injection a little bit more unique than Abilify Maintena, which is an every 4-week injection, is that you actually have the option to give it every 6 weeks or even every 8 weeks, depending on the oral dose. So this can be good for patients in terms of, the times they need to come back for the injection. The downside is that you do see that patients need 3 weeks of oral overlap, which in my experience tended to become an issue with patients, which is why it's great that we were able to, at least at Bellevue, add Aristada Initio to the formulary. So what Aristada Initio does is essentially gives you that 3 weeks of oral overlap in one injection. So the way that you would give these together is you would essentially give them on the same day at different sites. So you'd give the Initio 675, 1 dose, along with 30 milligrams oral, and then you would give the Aristada injection, whatever their dose is supposed to be, at a different site on the same day. You can technically space them by 10 days, but what I saw is that if we gave one injection and told the patient, oh, you can have the next injection tomorrow, they reneged on it. And they were like, oh, I don't want it anymore. And then we had a very difficult situation on how to deal with them getting half the regimen. So I would suggest, if doing this, to give them both at the same time and not to give the flexibility there. There is some dose adjustments for those who are on 3A4 inhibitors or inducers, or have 2D6 polymorphisms potentially. I would just look at the package insert. These are more rare scenarios in my experience. So you can just look, there's very clear-cut guidelines on the dose that you should give. And this is for all of the Abilify injections. Moving on to the risperidone injections. These are not as commonly used a lot of the times because we have the paliperidone injections. And so for those of you who are not aware, the relationship between risperidone and paliperidone is that paliperidone is the active metabolite of risperidone, 9-hydroxyrisperidone. So there's really no need to give the risperidone LAIs a lot of the time because we have the paliperidone injections that are available that don't require oral overlap, and they have better dosing intervals, like every 4 weeks or every 3 months or every 6 months. So risperidone Consta was the first atypical LAI available. I think it was like early 2000s, but again, has fallen out of favor because of the availability of the paliperidone injections. Rykindo was just approved back in January, so I'm not aware of any facilities using this as of yet. But the good thing about Consta is that it is they're very clear-cut dosing guidelines. So you're giving, based on the package insert, up to 50 milligrams every 2 weeks. The problem is the 3 weeks oral overlap. And the oral overlap is different for Risperdal Consta because it is in that microsphere formulation. So you have no drug release after the injection for 3 weeks. So if patients don't take any oral overlap, it can be worse than if they don't do it with aripiprazole, for example, because at least with aripiprazole, they'll get a little bit of drug in the blood versus with the microspheres have to burst, and they don't burst for 3 weeks. So it's essentially like handing them a bottle of medication and saying, take this in 3 weeks. So you're really putting patients at risk for relapse if you don't make sure that they take the oral overlap with Consta. And that's one of the major pitfalls of using it. Rykindo's new. I don't know what's going to happen with it. It doesn't seem that unique to me, but it does have 7 days oral overlap instead of 21. So maybe that's something good. The others that you'll see, Uzedy is new as of, again, April, but Perseris, I know some New York hospitals do have this on the formulary. This one is unique. Both of these are unique in that they're given sub-Q, either in the abdomen or the upper arm, except Perseris has to be the abdomen. The major problem that I have seen with Perseris is that it's only available with dose equivalents for 3 milligrams and 4 milligrams PO. I actually just saw a patient a couple weeks ago who came into our hospital who relapsed on Pharmacist because he needed a higher dose of Risperdal. So most of our patients with schizophrenia require probably 4 to 6 milligrams of Risperdal. So to limit the dosing to only 3 or 4 milligrams, this isn't going to capture a lot of patients. However, there's no oral overlap required. So if you do have those patients that do need those lower doses and don't want an IM injection, their insurance covers it, Pharmacist is right there for you. And again, Uzedy is new as of April, so I'm not really too familiar with this. I just wanted you guys to know that it's out there available. You may start to see this in the next couple of months. The Risperdal injections are unique in that they all have refrigeration required. So just keep that in mind. And then there's specific reconstitutions for all of them, essentially except for Uzedy. So I would just say, look at the package insert for those. Now, the most commonly prescribed LAIs are going to be your paliperidone injections. And most of you will probably be familiar with Invega Sustenna, which is the every 4-week injection. If patients are stabilized on this, you can eventually, if insurance permits, put them on Invega Trinza, which is the Q3 months, or the Half-Yara is the brand name of the every 6-month paliperidone injection. Paliperidone palmitate is the only, and Trinza and Half-Yara, these 3 are the only injections that have to be renally dosed. So as a pharmacist, this is usually like the first thing I try to remind about dosing. Make sure that you renally dose it. I'll talk about the dose adjustments on the next slide. Paliperidone palmitate's unique in that it has this kind of loading dose regimen where you don't have to do oral overlap. So essentially you're giving 234 milligrams on day 1, and then you're going to do 156 anywhere from day 4 to 8. And some may say even up to 10. Again, you can transition patients on oral risperidone to paliperidone, and that is likely the way you will see it the most. The package insert doesn't provide specific dosing conversion, so I didn't want to include them there. It's a little bit less evidence-based than the paliperidone equivalents, but essentially patients on 6 milligrams of risperidone probably need about 234 monthly, and then 4 to 5, you'll see 156. And so I highlighted or I bolded the 156 and 234 because those are the doses you're most likely to see patients on. So you're probably going to see 156 or 234 every 4 weeks. Those are the most common doses. Again, renal dysfunction requires dose adjustments, and actually the threshold is fairly high. So the package insert even recommends dose adjustments for creatinine clearance less than 80. I will say you can take this with a grain of salt. In my experience, we don't necessarily will do it if someone's at like a 75, especially if we think we need the medication. So there's probably some flexibility with this. But I think the key take-home point is that use is not recommended with a creatinine clearance less than 50. Many of the prescribers forget this. So this, as a pharmacist, we are going to have to be right on this. We did have one patient a couple years ago who went to a medicine service and had AKI for like 2 months. They were on medicine for 2 months, got their 2 injections, and developed neuroleptic malignant syndrome because they were dosed inappropriately on Invega Sustenna. So really, really important to kind of keep this in mind. Monitor serum creatinine, monitor for EPS. Now, once someone is stable on paliperidone palmitate for 4 injections, they can then be transitioned to the every 3-month equivalent or the every 6-month equivalent. And so I've listed the kind of the dosing conversions here. It's very regimented, very clear-cut, very easy to interpret. Lastly, I'll talk about olanzapine. Olanzapine you will not see used very frequently. The oral formulation is one of the more commonly prescribed antipsychotics, but because of the REMS program and the risks associated with it, you don't see it used much in practice. And the risk is really post-injection and delirium sedation syndrome, or PDSS. Essentially, there were some symptoms observed in the initial phases of this drug coming out, oversedation, delirium, and potentially you could see olanzapine overdose or symptoms looking like that. So there is this whole REMS program. I think the highlight is really that patients have to be monitored for 3 hours at the facility, which tends to become cumbersome, and there's extensive documentation required. So you're not going to see this much. I do know there's another olanzapine injection that is in phase 2 or 3. I'm not really sure which one now, but there might be more to come with that in the future. You may be thinking, what happens if there's an earlier a missed dose or a late dose? This happens all the time. The good thing is most of the package inserts have very clear-cut guidance. So if you look at the right-hand side here, it's for Invega Sustenna, it essentially says what to do depending on how long it's been since the last injection. So I would just consult the package insert, and that will kind of give you an idea of how to deal with the patient. Also, most of these injections are available in kits with pre-filled syringes and syringes that are provided to you with a specific, size and all that. So always use those. Obviously, the exception is going to be Haldol and flufenazine, which are in vials, and you'll just do that on your own. But I could spend 2 hours talking about all the different ways to administer these LAIs. So basically, what I would recommend is if you have to prep this and reconstitute it, just look at the package insert. Also, a lot of the manufacturers' websites have videos available, so you can just go there and you can have a visual, if you're a visual person, to see how to administer it. And so lastly, just some take-home points as pharmacists. We want to always prevent medication errors, which are very possible with these LAIs. So always make sure you're giving the patient the right drug. So like not Haldol lactate, which is the immediate release formulation of Haldol. You want to make sure you're giving the decanoate formulation. You always want to verify the last doses. I've seen cases where the dose wasn't verified appropriately and a patient got an injection a day apart. Make sure it's being given at the right dosing interval, and make sure the oral overlap is appropriate. And then the other thing is just making sure you inject at the right site. So you might have noticed that some can only be injected in the deltoid. Some can only be injected in the gluteal muscle. So just making sure you do it to maximize the drug absorption, making sure to do the correct dose and the volume. This becomes more of an issue with the haloperidol and the flufenazine, making sure you drop the right amount, and then just prepping it appropriately. Some of the preparations require very, very detailed, preparation. So for example, having to, Proceris, I believe you have to shake it like 50 something times in a certain way. So just making sure that you can follow that to just maximize the stability of the drug and efficacy. All right, now I'm going to hand it over to Dr. Brown.
All right, hi. Just give me a second to share my screen and get set up here. All right, can everybody see that okay?
Looks good.
All right. Okay, so now shifting gears here, I'm going to talk a little bit more about the legislation in New York, what it means for pharmacists, and then go over a little bit about training resources and also how to implement this if you are a pharmacist. So there's been a couple different bills that are in various stages. So we'll start off by going over the current legislation, which was this bill that happened to be signed in 2022. We'll go over how that legislation relates to the different medications that are available. And then we'll go over this amendment that's going to hopefully be signed by Governor Hochul any day now, and kind of what that changes from the 2022 bill that passed. And then again, we'll go over training and implementation. So here are my learning objectives. I want you to be able to discuss the New York's legislation regarding pharmacist-administered LAIs. I want you to be able to outline the process for administering these in a practice setting and discuss the environment and supplies needed to do this in your practice. So just a little bit of background on this issue. So New York is one of only 14 states that don't allow pharmacists to administer LAIs. So big surprise there. New York tends to be a little behind the 8 ball when it comes to pharmacists' scope of practice. So not really surprised by this, but I'm happy to see it progressing. So patients with mental illness struggle with adherence. This contributes to higher rates of readmission. So patients with schizophrenia, 50% of patients with schizophrenia struggle with adherence, and those that aren't adherent are 5 times more likely to be readmitted to the psychiatric hospital. So there's clearly a need for improved access to treatment for mental health disorders, but also substance use disorders. And this includes LAIs that Farah already talked about, improve adherence. So this is a snippet from the 2022 legislation that has already been signed. And this is right from Article 37 of the New York State Education Law, available on the Office of Professions website. So a licensed pharmacist within their scope of practice can administer injectable medications into the deltoid muscle pursuant to this section of the law for the treatment of mental health and substance use disorders as prescribed by a licensed prescriber acting within their scope of practice in the state. And in accordance with other regulations that can be promulgated by the commissioner. So I just wanted to highlight some key parts of this. So this part right here, injectable medications into the deltoid muscle. So this will prove to be consequential. Farah kind of already talked about some of the reasons that is. Not all of these are administered, not all these medications are administered in the deltoid muscle. Has to be for the treatment of a mental health or substance use disorder. And it has to be prescribed or ordered by a licensed prescriber. Now, it doesn't say patient specific. This will be something that gets updated in the 2023 amendment. So technically, as the legislation stands now, standing orders would be okay. But that's something that they want to do away with this new amendment. They want to make sure that it's a patient specific order or prescription. So here is more kind of that I snipped from this bill. And this is about the training requirements. So they want all the training for this to be accredited by this Council for Pharmacy Education. That could include IPPEs or APPEs for pharmacy students. And it's got to be approved by the Commissioner of the Department of Health in consultation with the Board of Pharmacy and other state agencies. So, and it can include these learning modules and techniques and everything like that. So even though this has already been signed into law, at least to my knowledge, there's no training program that has met all these requirements yet or been approved. So even though it's in effect, it's kind of not in effect because there's no training program that meets these requirements and everything that's been approved. And this is going to be another big thing that is altered with the new amendment. So here are all the psychotropic long-acting injectable products that are available. Like Farah said, there's new ones that are being approved, every day, basically. There's a olanzapine one that's in development. These 3 right here are all fairly new approvals. And this abilify cystolphy, that's a new one too. So this is all the products that are available. But if we go back to that part of the law that says we're only allowed to administer shots in the deltoid, it takes some of them off the table. So Zyprexa, Relprev, remember, that has to be administered in the gluteal muscle. So we wouldn't be able to administer that one. Another key piece of legislation is that we are not allowed to initiate treatment with LAIs. We can only give maintenance injections. So Aristada Initio, which Farah went over in her presentation, that's essentially a loading dose of aripiprazole and allows you to initiate Aristada on day 1. So because you're initiating treatment, that one is one that pharmacists couldn't technically administer. It's maintenance treatments only. Hafyera, this is the 6-month paliperidone injection. And because it's such a large injection volume, the dose is so large, it has to be administered in the upper outer gluteal muscle. So that's one that the current legislation as it stands, we wouldn't be able to administer either. And Uzedy, Rykindo, and Perseris, those are all those subcutaneous formulations of risperidone. So not only are they not administered in the deltoid muscle, they're not administered in the deltoid. It's like upper arm and abdomen for the location, the place of injection for those medications. And then Brixadi, this is another new approval for a buprenorphine, subcutaneous buprenorphine, long-acting injectable product. So the law as it currently stands allows pharmacists to administer 10 out of 17 products. So let's talk about this new amendment bill that's It's already passed the state assembly and it's already passed the state senate. So now it's waiting to be signed by the governor. And I believe she has until December 31st to sign it or not sign it. And then we're kind of just dealing with the 2022 bill, and things will kind of stay as is. But there's some exciting things in here that I think could be pretty promising in expanding, what medications are available and removing some of the barriers around training and clarifying some other things as well. So this removes the restriction that the medication has to be administered in the deltoid muscle. It also clarifies that standing out orders aren't okay. So it's not like vaccines. You have to have a patient-specific prescription. It also removes all that oversight of training. It's much more vague in terms of training. And it also clarifies notification requirements to the provider, which are very important. So now with this new amendment, if this passes, basically the only thing that would be off the table then is just Aristata Initio, because they still want to make sure that pharmacists are only giving maintenance treatment and not initiating, not the first dose of the LAI. So this would allow for 16 out of 17 products. But remember, Relprev is probably not one you're going to see just because it has that REMS program, and you have to administer this in a REMS registered facility with access to emergency services. So no outpatient pharmacies are going to be administering this. And this is just a marked version of the bill. So anything that is in red is what has been removed. Anything that's in green is additional text that has been added. So this is a markup of the 2023 amendment. So you see they removed this bit about the deltoid muscle, and they added that this has to be a patient-specific prescription or a patient-specific order. And then this is kind of the part that I wanted to highlight here. So the pharmacist shall notify the licensed prescriber that administration is complete within 5 days. And it talks about the different ways they can do that. They can do it electronically, send a fax, different things like that. And you also have to notify providers if the patient doesn't receive their injection. So maybe they show up and they refuse, or if the patient just no-shows, you still have to notify the provider. And then this was that big section that covers training. So they eliminated all that. And there's no longer the requirement about all the different Council of Pharmacy Education and Board of Pharmacy having to approve the specific the training program. Then now they've kind of left it more open-ended and just say that pharmacists have to maintain continued competency regarding the population served and the medications that are being administered. And this is another thing I wanted to highlight here. You have to get the patient's consent before administering the injection, and you have to provide an area for the injection that ensures patient privacy. So this is a great resource for pharmacist training on LAIs. This is available at AAPP.org. This is the American Association of Psychiatric Pharmacists, and they have this comprehensive psychotropic LAI training program. So it has the different sections over here. They cover all the pharmacology and dosing and different things that kind of Farah gave us a very concise overview of. And they also get into building a long-acting injectable practice. And you can even get a certificate of completion at the end. So I highly recommend this. They also offer this in-person training, which is nice because you can actually get hands-on training on how to do the injections at AAPP's meetings. And another great resource is this SMI Advisor. If you go to smiadvisor.org/about/LAI, they have this long-acting injectable center of excellence. And this is another useful resource because they have videos that show you, the different anatomical landmarks of how you do a gluteal injection, and they have videos of clinicians, doing it and everything like that. And yeah, between the two of those, you should be covered for training. Again, the medications, they're a lot different than vaccines. They have a lot of different quirks. So it's definitely important to know what you're doing before you decide to do this on patients. And now we're going to just kind of switch gears here and talk about implementation. And just kind of bringing my experience here. I've never given these injections, but I worked at a clinic where we had nurses that gave these injections to patients that were either traveling through Western New York or looking to establish psychiatric care in Western New York, but hadn't yet. And our clinic kind of served as a bridge for them. So the first steps are to get trained. The new legislation, it loosens those restrictions on training and competency. So the first thing I'd learn how to do is learn how to store, prepare, administer LAIs, and then something else that I'm missing here is how to procure them. So Farah mentioned that a lot of these newer LAIs are very expensive. So this is not a medication that every pharmacy is going to stock. It's a specialty item in a lot of senses. So establishing how you're going to procure the medication is important too, and understanding that it's a lot different than vaccines. Some of them might be more similar to how the vaccines work, but most of them are going to be different, and everyone has its different, storage, administration. A lot of them have to be reconstituted. The nice thing is that I think Farah mentioned as well is that a lot of them come in their own kits with everything you need, which makes kind of dealing with preparation and administration a little bit easier, but it's still important to learn the different requirements of each injection. And then the other thing I want to point out is that the injection techniques are different. So Farah kind of talked about Z-track injection, and that's done to kind of avoid the medication leaking back out. And I think we already got a question in the queue here about that. So yeah, immunization, we didn't have to worry about Z-track injection. But this is a new technique that you have to learn. It's easy, quite frankly. All you do is pull the skin, and when you inject it, you let go, and that essentially, prevents the leakage. And so that's something you have to learn about how to do. Some of these medications, you have to aspirate the needle, which makes sure that the needle tip's in the desired location, and that you're actually injecting in the muscle, and that you're not aspirating blood. And then a new one for pharmacists is how to inject in the gluteal muscle, which allows us to give a larger volume if we're doing half year or if we're doing things like Relprev. And then those newer risperidone formulations, those sub-Q, they require another different site, in the abdomen or upper arm. So there's really a lot more that pharmacists have to learn if they want to have the broadest skill set possible and be able to administer all these injections. And I just encourage you to use the resources that I shared earlier, and to really feel confident in yourself and that you're educating, you know what you're doing before you decide to implement this in your practice. So after you get trained and you're confident, the next step would be to develop compliant policies and procedures. And this is obviously going to depend on what happens with that amendment. But some things to kind of think about when you do develop your policies and procedures are, do you want to take appointments only, or do you want to also take walk-ins? So remember, patients would have to come, if they do a walk-in, either with their medication or definitely with their script, and then hopefully you have the medication. And then do you have physical space to administer this? So remember, you have to provide a private area. Now, that's not necessarily, it doesn't have to be an exam room. Even with the gluteal injections, patients don't have to pull their pants down, all the way. They don't have to completely disrobe. You can get away with like a partition or a curtain, if that's preferred and easier to implement. The site of the gluteal injection can really be accessed by just pulling the pants down, a little bit. They don't need to completely disrobe. And I started this bullet here, documentation and communication with the patient and provider, because this is really going to be the most important thing to figure out. I might also add procuring the drug. If you're not either a clinic or a pharmacy that routinely stocks these medications, that's going to be another really important thing to think about here, the LAI storage and handling, because kind of getting those three things to kind of work smoothly in your workflow is going to be really important. Making sure that you have the drug, the the provider provides the script, and the patient shows up. Those three things and getting that to work smoothly is kind of what I'd focus on in developing these sort of policies and procedures. Patient monitoring and emergency protocol. Every medication is a little bit different. I think the minimum that I'd suggest for most of these is just having the patient wait around for 15 minutes. And you can be doing other things like notifying the provider, scheduling their next appointment, and that can be included in that 15 minutes time. And then having an emergency protocol, that's going to pretty much mirror the same thing you have for vaccines, with the exception of the Relprev, which is a little different. And then I'd strongly encourage the use of a chaperone for gluteal injections, especially if it's a patient you guys don't have a relationship with. And that's just to avoid any sort of accusatory issues or anything like that. The supplies are going to be very similar to what you're used to seeing with vaccines. There are, alcohol swabs, gauze pads, a Band-Aid, and then for your first generation antipsychotics, which are in those the sesame oil vials that Farah showed, you'd need 3 ml syringes, 21 gauge needles, and you'd want 1 and 1.5 inch needles in case you have obese patients. And then disposable gloves are never a bad idea. And then, like I said before, these newer LAIs, they all come in pre-filled syringes, and you just got to read the instructions on the kit, and they tell you how to do everything. And if you do the AAPP in-person training program, they actually have the kits, demo kits, there for you to kind of experiment with and practice using, which is kind of nice because, again, since these medications are so expensive, it's really not something you want to mess up. Something we have happen at the psych center every so often is medication gets reconstituted, patient refuses it. Now, we're out $2-3 grand, however much the injection costs. So always make sure the patient's ready to accept the injection before reconstituting, before preparing the injection. That way nothing goes to waste. So refrigerator space, the risperidone injections, I guess all of them require refrigeration. Also, if you're going to do Vivitrol, that's another one that requires refrigeration. You want a sharps container, maybe some patient education materials might be wise, forms to document consent, the administration site, if the patient had any sort of reaction, and then access to an emergency kit, hand sanitizer, sink, so you wash your hands before and after, things like that. So this is a gross oversimplification, but this is kind of a brief outline of a suggested workflow. So I'd start out by confirming and scheduling the patient for their appointment. Again, could you take walk-ins? Yes, no. But I'd assume if you're starting out with this, you want to start out by taking appointments, maybe appointments only. So confirm and schedule the patient's appointment, identify the area that you're going to use to administer the injection, greet the patient, explain your role. I'm a pharmacist. I'm here to administer, your shot. Confirm that the patient's ready to receive the shot. Again, we've had instances in the psych hospital where we do that and the patient ends up refusing the medication, and then the medication goes to waste. Confirm that they're ready and have them sign the consent. And then inform that you're going to leave, go prepare the injection, and then return, explain where you're going to administer the injection. If the patient's going to have to remove clothing or whatever in order for you to access their deltoid or maybe their glute, then prepare and administer. And then observe for 15 minutes. Again, this may vary based on medication, and this may not be something you want to do. Maybe you want to change that. And then during this time, I'd recommend scheduling the patient's next appointment, inquiring when their next follow-up with their psychiatrist or their provider is, documenting that the injection was given, and sending that communication to the provider. So remember, these last 3, that can kind of be done as you're observing. So it doesn't have to be, wasting time. You can kind of be doing these things all at once. So billing is a challenge, and it's really going to depend on how things shake out in New York State. But if you're in a pharmacy, you're going to have to work with your pharmacy software company or your billing service and establish the infrastructure necessary to bill for LAI administration. The good news is that many third-party payers provide coverage for LAI administration. There's Medicaid, there's Medicare Part D, and private insurance. And then pharmaceutical companies, I started this one. So we had some luck with this. And basically the way it worked was, it was called the Otsuka Assure program. And we registered our site with Otsuka and said, we are trained on how to administer, you know, Abilify Maintainer. If you're a patient looking to have your shot administered, you know, we're happy to provide that service for you. And what ended up happening is patients that were traveling from, you know, other states, passing through Rochester, passing through Western New York, would be referred to our clinic. And we would obtain the drug from the pharmacy, specialty pharmacy. We used one in Buffalo, and they would deliver the medication to us. The patient would show up for their appointment. We'd administer the medication, and we'd be reimbursed $50 for obtaining the medication from the pharmacy for the patient, and then $50 for administering the shot for the patient. And again, we are having nurses do this. So that's one program that I'm aware of where you can get reimbursed directly by the pharmaceutical company, just for helping with coordinating care and sort of that continuity of care. The pharmaceutical companies are very interested in supporting that. So, and Otsuka is not the only manufacturer with these medications. There are other manufacturers out there that do this sort of thing. Whether they offer reimbursement or not, that's something I don't know about, but I know that you can register to become a care center with these different companies. And what does that do? That enables patients and providers to basically find you online, and kind of is a way for you to market your service a little bit, and also just serve as a resource for patients. So if you decide you're going to administer any of these injections, I highly recommend becoming a care center and registering with these different websites here. Now, I didn't list, this is not comprehensive either, so you have to look up the medications and see if they have their care center websites for each of those. The last thing I wanted to talk about is this Kendra's law. So this is something New York State specific. And this established assisted outpatient treatment programs for the counties in New York State. And it essentially allowed for like treatment over objection on like an outpatient basis. And it's specifically for patients with a history of violence towards themselves or others. And basically what it does is it legally compels patients to accept treatment. And a lot of times these patients are maintained on LAIs. So the take-home message here is that these programs vary by county, and some patients will be in AOT and maintained on these medications. So, you know, if your clinic, your pharmacy wants to start administering these medications, might be a good idea to contact your county's AOT program and, you know, let them know that you guys want to be a resource for them. So I think that about sums it up for my section here. I think we have some questions next. Yeah, so let's see. Do we want to get right into the assessment questions now, or?
Sure, that's fine.
Okay, so I guess mine are first, so I'll do mine, and then Farah, I don't know if you want me to advance your slides for you.
That
But
works.
okay, great. So the current law in New York State allows pharmacists to administer the first dose of an LAI medication to a patient with a mental health or substance use disorder, provided they have a patient-specific prescription from a provider. So this one's false. Remember, pharmacists can't initiate treatment with LAIs. They can only give maintenance doses after, you know, a nurse or a psychiatrist or a different provider has already administered the initial injection. Okay, and then under the new amendment, how long do pharmacists have to notify a provider if a patient misses their injection? So it's 5 days. Seems kind of long to me, but remember, each medication has different requirements for management of missed doses and grace period. So it's not like a patient needs to get, you know, their injection exactly 30 days every month. There's always like a grace period. Each medication is a little bit different, but just consider 5 days is the minimum. So you might want to notify sooner in some cases. And then
Right.
Farah.
I'll take it from here. Yeah. So which of the following LAIs require sub-Q administration? You guys can put it in the chat. Okay, so I'm seeing A. So yes, that's the correct answer. So risperidone extended release. So those are the only sub-Q. Yeah, great. All right, I think that's everything. So I guess we can go to questions now.
Sure.
Sure, so I'll go ahead and read the question, and you can decide amongst the two of you who would like to answer. So the first one we had was, how does QTC prolongation potential compare between the long-acting injectables and immediate release IM/IV antipsychotics?
I can take this, Jeff, if that's okay. Yeah.
please.
So I think the classic example is IV haloperidol. We know is going to be the worst in terms of QTC prolongation. Have we had systematic studies evaluating LAIs specifically for QTC prolongation compared to the others? I'm not aware of any. So I think of kind of haloperidol as being the highest risk. And then in terms of the others, I kind of think of the risk similar to what the oral formulation is until more literature comes out.
Thank you. So the next question was, I don't recall the APHA immunization program discussing Z-track methods, and it doesn't cover LA injectables. Have you included LA injectable technique training in your curriculum at UCI? So Farah, I think that one's for you.
Yeah, that's a great question. We're a new school, so I'm designing our therapeutics course right now. We're starting it in January, and the issue is that the quick answer is partially, probably. We don't do it in where they learn about immunizations. I'm going to try to incorporate it into the therapeutics module just because I think it's important. The problem is finding time for it, because for those of you who teach in psych, schizophrenia is a tier 2 topic for ACCP. So I can't put too much time in there learning, having them do all the injections. So I'm going to try to give them a little bit of a taste of it and talk with some of the other lab courses to see if we can integrate it a little bit. So quick answer is I'm going to try because I think it's important.
Thank you. Have either of you seen an increase in collaborative agreements for pharmacists to administer LAIs? How many were in health systems versus community practice?
So I can take this one if you want, Farah. Again, this is all pretty new. And even though that 2022 legislation has already been passed, I'm not aware of any place that's, doing this yet. And I think that's partly because there's like a lot of uncertainty around like the training requirements that were in the original bill. And to my knowledge, at least, there's no program that's met those requirements, basically, that's been approved by the Council for Pharmacy Education and the Board of Pharmacy. So I think that's why they're kind of removing that with the amendment, and then it'll kind of grow from there, hopefully, and there'll be some pharmacists that are doing this. But to my knowledge, at least, there's no place that's currently doing this yet.
If you have an admitted patient on an LAI, but they are acutely agitated, is it safe to give a PRN dose of an immediate release antipsychotic?
I can take this. Yeah. Yes. And this comes up a lot. They might be psychotic because their dose is inadequate. Maybe they use substances, but if they're having symptoms and they need to be treated, it is safe. I would just do the appropriate monitoring for EPS and, maybe QTC prolongation potentially, but no, I'm not super worried about that unless they're medically ill or like an elderly patient, female patient, something like that. Yes, you can.
Okay, I think we have time for one more question, then we're going to have to wrap up. The last one I'll address is there data that shows that other states were able to address care gaps through passing the LAI injectable bill? Curious to see what has been published and shared with our interprofessional colleagues.
Are you aware of anything? I'm personally not aware of any data.
I know much of the data out there is more patient satisfaction focused. I'm not aware of any economic related data out there. I think there's a gap in the literature and we should address that. But as far as I know, it's mostly like satisfaction based.
Okay, there's a few other questions in there. Certainly, if you still have questions that you would like answered, you can contact the speakers, but we're going to go ahead and wrap up now. So And the other thing I wanted to say is thank you to both of the speakers and happy Pharmacy Week to everyone. So the last items to wrap up, I'm just pulling up my sheet, is just a quick thank you to Dr. Khorassani and Dr. Brown for providing today's webinar. So I'm going to provide the CE codes now. I could stop recording.